of the committee, joined with by my fellow board members here, Tom Ginsberg, Lynn Katransky, Susie Drynan. I think that's who I see from the board. Today we are thrilled to welcome Cheryl Bettigole, Dr. Cheryl Bettigole, the Acting Health Commissioner of the Department of Public Health for the City of Philadelphia. She took the helm in May following the sudden departure of Tom Farley. She's got a great resume. She's been in public health most of her career. She's a board certified family physician. She previously served as the department's director of chronic disease and injury prevention and as a member of its COVID-19 pandemic team. Before that, she was in public health centers. She was chief medical officer of a federally qualified health center in New Jersey. And she ran the clinical director of Health Center Number 10. She was also president of the National Physicians Alliance in 2012 and 13, where she helped build a task force on gun violence prevention. Obviously a super salient topic right now. I got to know her a little bit during the work the Economy League did with the health department on the food economy, culminating in a pretty great report called Good Eats, if I may say so myself. So she's going to talk to us today about a wide-ranging series of topics affecting public health in Philadelphia. Obviously, COVID-19 is still top of mind for everybody. Are we prepared for the winter surge? How is COVID-19 affecting other public health crises like the opioid crisis? So I will turn the floor over to her, and we will take Q&A in the chat, and I will curate those questions. So please put them there, and I will read them out when we get to Q&A. So let her have about 20 minutes on the floor, and then we'll go to Q&A. So take it away, Dr. Bettigole.
So it's a real pleasure to be here. I see some familiar names and familiar faces, including Pedro Rodriguez, who I have a running joke with that everywhere I go, Pedro is there. So good to see that that is still true in the pandemic. So are you able to show my slides?
I'm getting that for you 1 second. I'm sharing my screen for you.
Thank you. So I put together some slides. These are about COVID, but I'm happy to talk about whatever other topics you'd like to talk about. It just seemed like that's really the most topical thing right now.
Are you seeing the slides now?
Yep.
Okay.
You want to just, yeah, this is perfect. So first, just a rundown on where we are right now with the pandemic. We look at our running average for case counts, and we're at 263 a day. Just to give you some perspective, in the heart of the summer, we were down below 50 pretty consistently for a few very happy weeks. Wait, can you go back to that previous slide for a second?
Sorry.
Okay. But in the worst parts of the pandemic, we had well over 500 cases a day.
Oops, I'm sorry. Sorry.
Our weekly positivity rate is about 3%, which means we're not picking up every single case, but we're picking up most cases. So that means our case count is pretty accurate. Hospitalizations just over 200, and this is down from around 230-ish in early September. So, we've been pretty flat for the last few weeks in terms of hospitalizations in the Philadelphia hospitals. In terms of vaccinations, we are doing pretty well for big cities. We have little over 86% of our adults who've had at least one dose. More than 70% of adults are now fully vaccinated in Philly. And boosters, we have just barely scratched the surface. We've given about 24,000 boosters. In that first week of approval, we know that there were somewhere around 61,000 people eligible. So we have a lot of work still to do on boosters. And of course, that number goes up over time. Next slide. So this is looking at the average case counts. And just to show you the impact policy can have here, this is a graph that starts in mid-July when case counts were very low. You okay?
Yeah, I'm just trying to get back to the controls for Zoom, but go ahead, sorry.
You can see how steep the rise in cases was. And it took a little while, I think, to convince Philadelphians that the rate of rise is really what is of interest here rather than the sheer numbers. So when we went from 50 to 100, we were very worried, but the rest of the city was not. But you can also see, the mask mandate went into effect August 12th. And what I was looking for was 2 average incubation cycles. So with Delta around 10 days later, we're looking at about 5 days for Delta in terms of not the incubation period we use for quarantine, but what is the average. But 10 days later, you can see that that curve dramatically changes. And, there's wiggle in there, but it's come down a little bit since, and we have not seen that same rise in cases since we've had our mask mandate in place. If you look at the next graph, this is from the Philadelphia Inquirer, but it looks at case rates by county. And you can see, that big peak that happened in the winter. You can see that Philly hit early and then closed down, and we came down before the surrounding counties. If you look at what happened, and that we are the bluish gray line at the bottom on the right side, you can see that the mask mandate brought us down dramatically and has kept us down low. And it's particularly interesting because we're doing a little bit, I hesitate to say this because it always makes me nervous, but we are doing a little bit better than surrounding counties that are much more affluent and have higher vaccination rates. So, masks are very helpful, as we know, but it's nice to see it. Next slide. All right, so this is from our data dashboard. And if you look at phila.gov/COVID, you can go to the data section and you can pull this up yourself. There are 4 tabs, but the ones I look at the most are the residents with at least 1 dose and the residents who are fully vaccinated. So what you're looking here is the dashboard for residents with at least 1 dose. And you can see that overall we're at 86.3% of adults, 80% of eligible people 12 and up. You can see from that map that there's definitely still disparities in who gets vaccinated or who has been vaccinated. But you can also see let me see, can you make this bigger?
Yeah, let me see here.
I'm saying you can see it, but you can't. Okay, hopefully you can see this now. If you look at the top row of graphs, the blue line is African Americans, the bluish green, a little bit lighter teal line is Latinos, the orange line is whites, and the gray line is Asians. And what you see on the 2 graphs on the right side, 45 to 64 and 65 plus, you'll see that we've actually managed to erase our disparities. So, the highest rates are among Asians and Latinos. The Blacks and whites are pretty comparable, but we no longer have disparities in vaccinations for those 45 and up. For younger adults, we still have a ways to go with Black adults, both for teenagers and for 18 to 44. But for Latinos, again, we've been able to erase those disparities. So we're still working hard to reach the people we haven't reached as much. But you can see, what a difference that makes. And a piece of what happened there was the FEMA clinic at Esperanza. So on the North 5th Street corridor, we put a very large vaccination clinic in collaboration with the Esperanza Charter School, which has a big community presence. And they worked with us to help get people into that site. And I think that then resulted in a large number of people in that community who were vaccinated, who would talk to their friends and neighbors and family. And so you see that very steep rise that happened starting in about the beginning of April, and it just kept going. If you look at the graph of race by week, you can again see that Latinos are doing actually slightly better than whites in terms of vaccination rate, but we still have some way to go in terms of Black residents in the city, although that gap is closing. Next graph. I'm sorry, next slide. So this is a look at breakthrough and the impact of breakthrough. And, although we are seeing with Delta a little bit of a rise in breakthrough cases, including breakthrough hospitalizations and deaths, still the vast majority of people who are getting COVID, who are hospitalized with COVID, and who are dying from COVID are unvaccinated. When we kind of break down the breakthrough hospitalizations demographically, we do see that across the board, Black city residents are at higher risk of breakthrough infection, breakthrough hospitalization, not breakthrough cases, just breakthrough hospitalization. So as we work on our booster outreach, we are using that information to target the booster effort. Next slide. So overall, and we just put out an updated plan for our pandemic response, but basically, vaccines and masks are our most effective weapons. And so that's really where we're putting our energy. We do need widespread access to low barrier testing, especially in congregate settings. This is a challenge because there's a shortage of testing materials. So, the presidential announcement of $1 billion for home tests is going to be a huge help. But in the meantime, there are some shortages. We are testing between 0.5% and 1% of the city's population every day, which is just mind-boggling. There was a time when we were really desperately trying to get up to 5,000 tests a day, and now we routinely do 10,000 and sometimes 14, 15,000. It's still not enough. And people are experiencing, waits to get a test that we don't want to see because we want people to get tested right away. So we're kind of scrambling to try to get more testing access. But, at the same time, testing 0.5% to 1% of the city's entire population in a single day is a lot. And I think that without the widespread access to cheap home tests, we're going to really struggle. So, that support will be a big help.
It's possible.
I mean, it's a common name, I would guess.
Yes.
So for isolation and quarantine, there are some people who need support. We do run what we call an INQ hotel, which is a site where we provide on-site support, making sure people have food, they have wellness checks, things that help them to stay where they need to be if they're not able to do that at home. And that's been running for months in the city. Overall, we're using policy tools that focus on the least restrictive necessary measures. And that's been consistent over the last few months. And that's also the reason to focus on vaccines and masks rather than closures and capacity limits. Outreach and education are critical to ensuring ongoing community participation. This has to be a partnership with community or we won't get where we need to get. And our strategies have to be informed by data. A piece of that data is community input and community voices, not just the numbers. Next slide. So interesting day to be talking with you all. So today is our deadline for at least one vaccination for healthcare workers at long-term care facilities and hospitals. It's also the deadline for students, staff, and faculty at colleges and universities to get at least one shot. We do allow for medical and religious exemptions with regular testing. The testing frequency depends if you're healthcare or colleges and universities. There are no philosophical exemptions. So people can't simply test out of being vaccinated unless they actually have an approved exemption. And then next Friday is our deadline for all other healthcare workers. So the reason for these mandates, we've had about 3,900 deaths from COVID overall in Philadelphia since the beginning of the pandemic. Nearly a third of them have been in long-term care facilities. Every week, I get reports on the cases in nursing homes, and we continue to see cases. And what we'll see is a pattern where we'll see a few cases among staff, and then we'll see cases among residents. By and large, nursing home residents don't leave the facility, so it's being brought in by staff who live in the community and are at risk. Overall, about 20% of people who live in nursing homes in the city of Philadelphia have died due to COVID. I will tell you that number is actually low compared to the national average. And a piece of that is that we kind of did the opposite of New York State. So New York State mandated that nursing homes, for a while, the nursing homes accept people back, even if they were COVID positive. They stopped doing that after a while because it was a terrible idea. Philadelphia mandated that nursing homes only accept COVID positive patients and only keep COVID positive patients in-house if they had a separate area, a separate wing, the ability to stand up a COVID positive area that would be separate and would be staffed separately from the rest. So you wouldn't have staff going between somebody with COVID and somebody without. And that's probably why it's only 20%, but it's still 20%, more than 1 in 5 nursing home residents died from the pandemic. And we continue to see cases regularly, so hence the mandates. Next slide. And this is my last slide. So this is hot off the presses. So, this is nationally available data. It's public data on vaccination rates among nursing home residents and staff. So the red is staff. And what you're seeing here, the mandate was August 16th. And you can see the inflection point in the graph, right? So as of August 15th, 64.1% of nursing home staff had had at least one shot. The graph then takes a turn up, and as of the 10th, so 5 days before the mandate, 87.4% of residents have had at least one dose. If you were to follow that line across without the mandate, without that inflection point, we would be probably at around 70%, it looks like. Just, following the slope of the line, not making any assumptions about people would do. So that's a pretty big impact from the mandate. And that's before we have our last 5 days before it takes effect. It also doesn't include the number of people who have approved exemptions. So I think overall, we are probably going to be above 95%. I know from the hospitals, they're looking at somewhere between 0.5 and 0.7% of staff not meeting the compliance, either through vaccination, which is almost everybody, or through an approved exemption. So, mandates are very painful, and I've heard a lot of yelling recently, but they are also really, really effective. And we just can't afford to go through another winter the way we went through the last winter in our nursing homes. So I'm going to stop there. I'd like to open it up for questions, discussions. It doesn't have to be about COVID. That's just kind of where most of our data is right now, but there is actually a lot else going on.
I'll take the chair's privilege and ask first question. Maybe we'll spark some others. Are we seeing disparate access to testing across the city? Because where I live in Northern Liberties, it was very easy for me to get a test with very short notice, less than a day's notice. I just walked into an urgent care clinic in Northern Liberties, or actually just walked up to the outside door. Someone swabbed my nose, and like 5 seconds later, I was done. And 2 days later, I had the results, and it's covered by my insurance. So have we seen that there's just limited access in certain neighborhoods, or across the board?
It's complicated. So there are testing sites very well distributed around the city, and we put a lot of work into that. There's a difference, though, between getting a test if you have symptoms or you have an exposure, and getting a test as a surveillance test, or just because, before travel, for some other reason. So for one thing, insurance is actually only mandated to cover testing if you have symptoms or an exposure. It's not mandated to cover surveillance testing. So that means people are looking for the free sites. So sites that are either run by the city of Philadelphia or one of our funded sites. That right there is going to be, it's not going to include very many urgent care centers. There is one that's part of our system, but that's going to be a limitation. And then it just depends. There may be more demand because there are more cases in low income neighborhoods. There may be more demand in those neighborhoods.
So question from, and I see you, Andy. Question from Pedro. What is the situation with public school staff and students? Do we have data on them?
So we ran a match for the schools, but it was quite a while ago. So I don't have, it's something we do for them quarterly. I don't have updated data since they put their mandate in place. I believe their mandate has a deadline of November 1, though, so it probably is too early to really look at those numbers. In general, teachers have very high rates. This is what we see in lots of, the lower vaccination rates are going to be among the service workers, the food service workers, and the janitorial staff. For kids, we have the data on the 12 to 17-year-olds for the city, but not for, it's not separated out by school district.
From Linda, of all the groups who have not been vaccinated, healthcare workers are the most surprising. Why do you think they are reluctant?
I mean, a lot of this has become partisan politics, right? And I want to say that it's not the more highly educated healthcare workers, but that's not entirely true. I mean, very few doctors are unvaccinated. The last I heard, the vaccination rate among doctors nationwide was about 98%. But there are significant numbers of nurses who are. And people have made this about, the sort of my body, my choice kind of language, except that, all of us kind of know in healthcare, when we commit to be healthcare providers, we are committing to the best service of our patients. So it's a little hard to swallow. I don't know, but I think this is why it felt like we needed a mandate in these vulnerable settings, because people aren't making choices that are fair to patients. So
Personally, I agree entirely. Andy Toy.
Hey, Dr. Bettigole, Cheryl. First of all, thank you for all you've been doing. And, you came in at a very, very, very difficult time about a year ago, I guess it was, when all that stuff hit the fan. And a lot of us were unhappy about the inequity that was the inequities in terms of testing and then vaccination availability. But it seems like we're in a lot better place today. And I think that's because, in a large part, to the efforts of you and the city of really pushing it out there and making sure communities across the city had access, because not everybody would want to go to the convention center or any of those other facilities. It really is a city of neighborhoods, and we have to remember that. And people are kind of stuck in their neighborhood sometimes. My two questions are, and you probably already answered this, when is the 12-year-old and under 12 years old going to really be available? Because I think that's going to change the whole school district dynamic. And then the other question is sort of a rhetorical question, I guess, is, are insurance companies doing anything, and are people being charged if they basically are unvaccinated and using up our resources at hospitals and centers because they've refused to be vaccinated?
So vaccines for 5 to 11-year-olds, if all goes well, we're guessing November 4th, but that relies on the committee making that decision and everything going forward as planned. So, but that's what we're hoping for, would be, early November, we'd be ready to go forward with 5 to 11-year-olds. The 6-month to 4-year-olds, we don't have an estimated date for. And that's going to make a big difference in ECE sites and, to families in general. But we're optimistic about having vaccines for 5 to 11-year-olds very soon. In terms of insurance companies denying care for unvaccinated people, irritated though I am at the whole political divide around vaccination and people making poor choices, I think that's a very dangerous precedent. No one's talked about, well, people have talked about it, no one's doing that. Think about where that would go.
Well, we do pay for, just to comment, we do pay for, like, if I smoke, I actually have a higher insurance rate than somebody that doesn't. So that's my choice.
Right, that would be different. A higher co-pays or higher premiums would be something different, but not like being charged if you got COVID. Yeah, I think, I've heard of some places doing that. The place that I'm a little bit worried about is lots of people assuming that their insurance is going to pay for surveillance testing. And, in the way of healthcare bills, you get them really late. So like you do a thing and then like 3 months pass and then you get the bill. So that could potentially be very bad.
Cool. Thanks for that question, Andy, and great answer. Ginsburg, what vaccination message works best with resistant or skeptical folks? He's asking for a friend.
There isn't a single answer to that. What doesn't work is yelling at people. So, just keeping the conversation going, honestly. I mean, with the data we have, people who decide to get vaccinated, because, I'm curious about this, like between 12 and 20,000 people every week who haven't had a first shot or a second shot suddenly say, today, I'm going to go get my shot. And it's been about the same number consistently for like the last 6-7 weeks. And I keep wondering, like, you waited all this time, why today? And what we're hearing from people is, it's the same things that it was earlier on. Like they do it for their grandmother, they do it for their kids, they do it, sometimes because they had to for work. So we're getting some of those. But, people like, it's conversation. It's refusing to engage in the head bashing, yelling at each other kind of discourse that's so rampant everywhere, and just like continuing to talk. I talked one of our staff into getting vaccinated about a week ago. And like, I swear I did not say anything that he hadn't heard, I'm sure 1,000 times, but like, it was, well, and we have a mandate, but we've had a mandate. So it's a hard question to answer.
Well, I have a dear friend that flew in from Atlanta this weekend, and the saying, you can't choose your old friends. We have very different politics. Let's just keep it at that. And he refuses to get vaccinated. He refuses to vaccinate his kids, and where he lives, there's no mandate. But he and his daughter both had COVID. So they're like, well, I have probably as many antibodies as you do. Like, why can't I sit inside an Philly restaurant? Because we had to, I had restaurant reservations. I just assumed they would be vaccinated. So we had to move outdoors. And that was a problem the whole weekend they were here. I mean, luckily the weather was good. So it's interesting. There's this whole strand of people. He made me listen to this podcast. It was 3.5 hours long with this guy, Alex Berenson, who I'm sure you have heard of.
Yeah.
This is who the conservatives listen to. They believe this guy. So there's like this deep prior knowledge among people that, Cheryl Bettigole is part of the establishment, and the establishment is bad. And even though, of course, their leaders are establishment too, but consistency is the hobgoblin of small minds. So it's an interesting dilemma. I'm fascinated though by the people who are, vaccine resistant or hesitant. I kind of get why certain minority populations are skeptical of the medical establishment after years of abuse and structural racism. It's harder for me to get why members of majority populations are so skeptical. Anyway, that's my soapbox comment. I'll read another soapbox comment, not from our good friend Bonnie Grant from the CVB. On behalf of conventions and meetings, thanks Cheryl and Dr. Epstein for working with CVB to enact safety protocols and guidelines for the return of meetings and conventions that before the pandemic employed 273,000 people in our region. Stunning number. We are very optimistic for 2022 and beyond. Meeting customers are very impressed with our vaccination rates. So I guess that's a comment from our good friend Bonnie Grant.
Can I just add to that?
Yeah,
I am so waiting for conventions and meetings to be in person, because every time somebody asks me to be at a a remote conference, it's useless.
Yeah, we're holding the Economy League is doing our leadership exchange in person, and we required a vaccine mandate for everybody. And we're gonna mask up whenever people are in large groups. But we are, frankly, we had a couple of board members that I was pretty shocked at who said, well, I'm not checking that box, and we had to tell them they couldn't participate. And it was not a happy conversation, but one very large contributor, in fact, but not putting people's health at risk for a few coins. Linda has another question. Oh, sorry, Tom, did you have one? Or someone, did I miss a hand? Nope. So Linda's next question, do you know anything about the chiropractors who have become anti-vaxxers?
It sounds vaguely familiar, but I don't. I mean, they would count as healthcare providers in Philadelphia, so they would be required to get vaccinated.
Any elaboration on that, Linda, or no?
Somebody's trying to ask a question with some.
Hello, I'm on the telephone. I have a question.
Linda, I can't. You're breaking up. So I'm going to go to.
There is somebody with a phone number only, no name, who's trying to. I think is trying to.
560-5601. Is that the person?
Yeah, 6501. Yeah.
Yeah.
Yes. Am I up?
Yeah, please identify yourself.
Great, thank you. John Chin. Hi, Dr. Bettigole. John Chin
Hey,
with the
John.
Philadelphia County.
Hello, John Chin.
Hi. Yeah, it's I'm finding it's difficult to be on the phone. Sorry about that, but I have a not necessarily a COVID-related COVID question, but actually, is there coordination or a strategy from the health department regarding flu shots and COVID booster shots? Or
Yeah, so that's a great question. We are worried about this flu season, that it could be a bad flu season from what we're hearing. We're trying to, obviously promote flu vaccine, but also to ensure walk-in access and that people can get flu and COVID vaccine together, which they can. I think what I've been told is that there's a lot of community skepticism about doing that, so that we shouldn't necessarily push that too hard. But, the more flu circulating, the more overloaded our ERs will be, and they are already at capacity. The one other thing I just want to add, since we have both John and Andy on this call, who are both really very, very helpful to the department as we were trying to develop a strategy for reaching many communities in the city that we hadn't necessarily reached early on. There are many things we've learned from the pandemic. One of them is that we need to really rethink and coordinate our community outreach strategy and our ways of building relationships with neighborhoods, so that we're not doing that in silos, division by division. So we're putting together some internal ideas, then we'll be reaching out to community groups to kind of put together a larger plan for that. But, that needs to also live in the commissioner's office to some extent and have some coordination, which it hasn't before. But it's a really critical part of all of our work, not just on COVID, but in general. And, I think with the pandemic, we've seen just how important those relationships are to getting work done. So thank you both for that.
I see Sue Salkowitz has had her hand up for a while. Hope it's not too tired, even though it's a virtual hand.
Hi, Cheryl. This is Sue Salkowitz. How are you? I wanted to ask a question about the, can you hear me?
Yep, we hear you.
Yep.
Okay. About the record keeping with regard to the immunization information system and the reliability of reporting from people who got their shots from pharmacies, adults who got their shots from pharmacies.
Yeah, there's good and bad here. So we have very reliable data for people who are vaccinated in Philadelphia. So the pharmacies don't all electronically report, which is our preference. Some of them give us what we're call a flat file, or a database, and then we have to upload that. That particular flaw, and it works in Philly, our data is accurate, but that we think is a piece of the problem with the federal data. It doesn't seem like all of those flat files actually get uploaded, because there are massive gaps between the numbers the feds have and what we have. There are also, we lack a national data system. Israel was able to do the data analyses they've been able to do because they have a record for everybody in the country that is their health record, and they can query that and figure out who's vaccinated, who isn't, let you know you didn't get vaccinated yet, please come on in. They do the same, by the way, for cancer screening. They don't do that in primary care. They do that by country, you are over 50, you need a colon cancer screen. I'm very jealous of this because we can't do that. But for COVID, it's been particularly bad. The state and the city can't communicate. So we know the number of Philadelphians vaccinated outside the city. We don't know their names. So yeah, that's cute, right? And if you got one shot in the city, one shot not in the city, that's going to be a problem. So that's probably part of the gap between our one shot, two shot gap is bigger than you'd think, bigger than it should be. And a piece of that is probably people who got one shot outside the city. There needs to be a national database for stuff like this so that we all know who got vaccinated. And we have not yet, as a country, figured out how to do that. But we
don't hold your breath. They're not going to do that.
Yes, but to answer, we do have data on people.
That's a step away from fascism, giving people information. Don't you know that?
Yes.
No, the not having a national database is not just a political issue. It really has to do with the relationship between state and federal health. And as you may know, I work on the registries, and this is a terrible problem around the country, not just Philadelphia versus the state of Pennsylvania, but also New Jersey, Delaware, you know. And we have neighbors that went to Allentown to get their shots when they first came out, and the big health systems here were not giving them. St. Luke's was giving them in Bethlehem and Allentown and Phillipsburg, and people drove up there to get their shots. So, you know, we know the state doesn't send to do anything with you.
Yeah, and that's why when you look at the vaccination rate for elderly people in the city, according to our numbers, that's why it looks as low as it does, because some people went outside the city and got vaccinated, and we don't have that demographic breakdown. So our totals are pretty accurate, but the breakdown by race, by age is missing a lot of people.
I think most of those people were white, by the way.
I do too, and I think that's the reason that we're seeing the white rate be slightly below the black rate for 45 and up.
Thank you. Good luck.
Other questions? The chat is kind of quieted down. Do we have any other hands up? I guess there was a question that I sort of posed in the intro about, and you know, John brought up the issue of the flu shot and COVID interactivity. I wondered if there's anything you could say about sort of the opioid crisis. You know, we were in an opioid pandemic before this corona pandemic. So what are you seeing? What are the strategies? And I know I've heard of some of them, but if you can give us a little bit of a rundown on how that interaction is happening.
Yeah, I mean, so the numbers for overdose deaths are just as bad as they were. You know, we're over 1,200 for the year. And interestingly, close to half of those are stimulant involved. So the opioid epidemic in Philadelphia has kind of evolved. It was a few years ago largely white and almost entirely opioid, and you know, increasingly fentanyl. And we have seen a pretty marked increase in overdose deaths among Black and Latino city residents, and something like 48% are stimulant involved, largely cocaine. We don't currently have anything to offer people with cocaine use dependence. And there are a couple of strategies that we're actively talking about with partners that could change that. One of them is very complicated to get permission to do and funding to do, which is contingency management, which is effectively paying people not to use. The other is cognitive behavioral therapy. Both have some evidence behind them. Both are tough to implement. But, you know, if half of people who die of an overdose, and the overdose they're dying from is typically fentanyl, but if the drug they were trying to take is cocaine, then targeting our strategies toward people with opioid use disorder isn't going to reach them, because they don't necessarily think of themselves as people with opioid use disorder, or even people who ever take opioids. It's that their drug is contaminated. So a piece of what we're doing is an in-person survey trying to understand of people with substance use disorder, or people on the street, trying to understand what they want to be taking, what they're trying to take. Because it might be, and I am very bad at this terminology, but you know, there are people who are intentionally taking cocaine combined with opioids, which has a name that I don't remember, but like they want that particular high. And then there's people who are just trying to take cocaine, but you know, drug dealers are not notorious for caring a lot about what's in their supply. And because there's so much fentanyl contamination in everything, that's a real problem. So those are strategies we're looking into, trying to figure out how we actually can reach people with cocaine use disorder. And then the other thing is counterfeit pills, which are increasingly becoming a problem. And this morning, I just sent out a letter, which is going to go to institutions of higher education, because people are buying pills on the street, and those pills have fentanyl in them, but they're not necessarily being told. Like they may think they're taking amphetamine or drugs for ADHD, and they're actually taking fentanyl, and they overdose because they're opioid naive, so they don't have any tolerance to the opioid. So there's a bunch of different things in the works. We're also working on a program to distribute fentanyl test strips. and to get people to start testing their drugs to see if there's fentanyl in it. Because, people who are inadvertently taking drugs that are contaminated with fentanyl are at very high risk for an overdose. And then, of course, continuing to try to get Narcan out, all the things we've been doing on opioids. So there's a lot in the works. Safe House is still pending, but it's a tough problem.
Yes, it is. I see Andy has his hand up.
Yeah, I was going to ask the question about the needle exchange, but you sort of answered it, I guess, that it's still pending, kind of. Is that what you said?
Well, Prevention Point is the needle exchange, and that's running. That's been running.
I mean,
Safe House
not
would be
needle
the-
exchange, safe, injection
Yeah,
site.
second injection site. Yeah, Supreme Court decided not to review our case, so that's a downside. But still, working on, is there a way to get this up and running? It would be a small proportion of lives that we could save that way. We're estimating probably up to 75 lives a year, but that's still a lot of people.
Ginsburg wants to know city, police, and fire, first responders, how's their vaccination rate, all the kind of first responder population, as well as correctional officers.
Yep, that's a problem. That is an ongoing discussion. And, I think the same comments about sort of politics and it's hard to understand why police and fire who have lost officers, that the top cause of death, of on-duty related death for police across the country is COVID. They've been to the funeral.
Wow.
Yeah.
I don't think people know that.
Well, I think, there's so much, I won't believe that. Like, the officers died, their colleagues know them, but somehow people put that out of their mind.
It's crazy. Absolutely Looney Tunes. Pedro, another question from Pedro. What would you say is the health of the city's health centers? And what advice would you give in that regard to the new administration? Do you mean the incoming governor or the next mayor, Pedro? Mayor.
So, I worked for the city health centers for nearly 12 years. I think they are a jewel of the city. We have some amazing people working in those places, and they continue to work their tails off and get almost no respect. It's kind of stunning. They need attention. There are capital needs in the city health centers that there's never enough money, and they have to get addressed. So that's a big priority. And then there's the need for Health Center 11. There's a need for another health center in the Northeast, which has been true for quite a while, and trying to work out the details so that we can actually build that. We have funding to do that, but lots of details to get worked out to make it able to happen. They are the reason that Philadelphia doesn't have more people who experience complications and early death from lack of access to care. And there's connections between the pandemic and primary care access that are really critical, that we're trying to kind of take learnings and build something new from, because people who have a primary care provider in a pandemic get a different kind of access to services than people who don't. And so the city health centers, one of the things I did early in the pandemic, I basically, Tom Farley gave me to disease control because chronic disease kind of could wait. So I was basically donated to disease control to do whatever they needed. And they had me on the phones talking to healthcare providers around the city, backing up their call center folks. It was really striking that there were primary care providers across the city who simply refused to take care of people with COVID or possible COVID, and refused to do testing, and just, felt that they couldn't possibly do that at the same time that our city health centers were open for business and seeing patients and, putting themselves at risk, but taking care of people. And so as we look at that and we think about like systems of access, they were calling their patients in as soon as there was vaccine. their high-risk people first, but calling people in to get vaccination. People who weren't enrolled in a city health center and didn't have a primary care provider to do that for them wouldn't have that kind of access. So we're trying to figure out a navigation system that is easy, especially for people who may not either read that well or speak English as their native language, who may not understand our healthcare system and who don't currently have access to primary care. Because for future pandemics, for future disasters, someone needs to have that relationship with each person in the city.
I'm a native speaker and I can't say I understand our health system. So
Nobody understands our healthcare system.
Sue, you have another, is there anybody who hasn't asked a question yet who wants to ask one before? But Sue, your hand's up, so go ahead.
Yes, I have one question, which
I'm
is,
sorry.
uh,
Hello.
what,
I thought you called on me.
I did, Sue.
Go on late. Okay. I wanted to go back to a question about the COVID and what type of documentation is required for people to get a religious exemption? I could understand the health exemption. And because you said there was no philosophical exemption.
So for religious exemptions, sorry?
I'm just curious because Dr. Offit says there is no such thing.
Right. Well, there's morally and there's legally. So morally, I mean, all the religious leaders of all the major religions have made statements to say that there is no reason for a religious exemption to exist. But the law department has told us that we need to allow them. So we have. What we require is a signed attestation of a sincerely held religious belief against getting the vaccine, which is a pretty low bar. Individual institutions, businesses can choose to have stricter rules than that. So they can, for example, Penn has a committee that reviews exemptions, and they don't allow, I think, most of them. The city rule is much, much broader than that, but people have to be willing to sign their name to that. And interestingly, not that many people are.
Not many people do, did you say?
People do, but it's relatively uncommon, despite, like angry people who don't want to get vaccinated also don't want to sign those attestations.
Oh, okay. That's interesting.
Fortunately, a lot of them think they'll go to hell for lying. So there's a trade-off there. Lynn?
yes, I just had one question, which had to do with the extent to which there's coordination between Philadelphia and the collar counties around mask mandates, because I find myself like driving 2 blocks and I'm in Montgomery County, and I go into a store and no one's wearing a mask, and I just keep mine on, but it is confusing, and I try not to be a policeman, but sometimes I feel like saying, shouldn't you be wearing a mask?
Yeah, I mean, we do communicate, but we are stricter. And, before we did our mask mandate, I mean, I was talking with the state and talking with Montco, but to a certain extent, the politics of Philadelphia are such that it may be easier to do something like that here. It is really striking, and I've heard this from a lot of people. And by the way, this is a little creepy, but we have surveillance data, so we know what happened when we passed the mask mandate, and we could see the graph go up. And people do wear masks more with a mandate than they did with a recommendation, because there was a recommendation before that. Montco has a recommendation, and we have a mandate, and politics is very local. All I can tell you is shop in Philly.
Good answer. Yeah, it's interesting. I spent a fair amount of time down the shore this summer, and you, God forbid, you tell someone in Atlantic County or Ocean County wear a mask. Like, those are fighting words down in those counties. So it's crazy how much differentiation there is. And also, correct me if I'm wrong, Cheryl, but I mean, the county of Montgomery County doesn't have as much power as the city of Philadelphia does, right? We're L&I that's going to come and fine you if you're not complying. It's like township by township, right?
I believe so. Yeah, I mean, and there are things that we can do as a county of the first class in terms of state regs that other counties cannot do.
All right, we are coming to the end of our time. We have time for one more question. If someone has one. I see Andy. You're like Arnold Horshack in this group here, Andy. I assume, Lynn, you meant to put your hand down because you already asked your question. So Andy, ask the last question, and then I'm going to let I guess Tom or somebody give the last word about what our next program is, if we have one. So
Okay. So trying to connect some dots here about the economy. So I have a friend that was in Brazil. He came to Philadelphia. He's actually Philadelphian. He's living in Brazil now. He came end of last year and he got his shot. He came specifically partly to get a shot, he and his wife. You know, I was thinking about traveling, but we're not traveling, but I was thinking about traveling. And the first place I looked at was a map or a list of what countries have the highest vaccination rates. And Portugal was really high on that. And I'm like, let's go to Portugal. This is cool. Is there a way that Philadelphia can use the vaccinations to basically, one, maybe tourist vaccinations? Like, because I also was at a thing at FDR this weekend, and the doctor there told me, yeah, we end up throwing out a bunch every day that we do our vaccination. Like, what? So if we're not using them, why not? If we could possibly give them to people who want to come here, spend money in our city, and then also advertise that we have the highest vaccination rate, if that's possible. That would be, I think that's a huge tourist attraction in some ways. It's weird, but it is something that people are looking at now.
I think Bonnie just got an idea.
Beyond the health
Can
department.
you give shots to people who don't live in your, I guess, who are from other countries visiting or other cities?
I think at this point we can vaccinate anybody who's in front of us.
A lot of this is Bonnie. A lot of convention organizers, in their duty of care, and many of them outsource this. But besides tracking the vaccination cards, checking them, and testing on site, some of them are offering vaccines on site for people who travel to the conventions.
Yeah, whatever it takes now that we have availability. Pedro, you asked this question. It's Ginsburg. Did any procedures change regarding the medical examiner's office following the move thing? And this is the absolute last question, and then we got to wrap up.
Yes, although I'm not sure if everybody knows, but Dr. Gulino did resign August 6th. We are searching for a new medical examiner, and that person will be charged with developing a whole new slew of policies and procedures in concert with the investigators. We're still waiting for their report.
Yeah, tough issue. All right, thank you, Dr. Bettigole. This has been a great conversation. I hope you enjoyed it. We've had some good questions. And Ginsburg or Lynn, who's gonna carry us out here with closing statement?
I can do it. Hey, thanks. And thank you very much again, Dr. Bettigole. We actually have Susie Drynan, among other. Susie's our leader of our board. She's on. If she wants to say a few things, that's fine. I'm just gonna jump in and say thanks again for everybody for coming. The next session is going to be in November. The exact date escapes me, second week or so in November, and we're lining up Claire Schubik Richards from the Pennsylvania Prison Society, and hopefully somebody else to join her to talk about conditions and situations in the city's prison system. So keep an eye out. Peel your eyes on your email, and we'll let you know. And thanks again, everybody. This recording will be posted on our website when we're able to get to it soon. So that's it. Thank you very much.
Thanks all. Have a great rest of your day, and we give you back 2 minutes.